So I'd like to say about one thing. Though there are a lot of technical stuff related to the mental health, but one thing has been always seen, that mental health is also a combination of how a person think about himself or herself. We all know that there was a famous professor who just took a glass of water, half filled, and the people may think, okay, he's going to just tell half full or half empty, or maybe our Prime Minister Modi, once he demonstrated that thing, he said that I won't say that it is half full with water. He said it is also half full with air. It all depends, how you look at the thing. But that professor, how he demonstrated that you keep holding that glass for long enough time, maybe throughout the year, maybe throughout the day, then it creates a lot of pain in you. So it is just like a small example, and most of the mental health happens when you are holding those grudges, regrets, unspoken things, withheld communications. So those things are making a big impact on the mental health. So there is a possibility of managing that thing in a medical and a clinical way, and also in a very different way. And we all know that there are research around epigenetics and other things. So what we say in India, health is known as the swasth. And the swasth is like swa me sthit. That is swasth. Let me explain in English. Centered in one's own self is being healthy. When you are centered in your own self, then you are away from any influences or any feeling that you are not good enough, you have done this thing to me, so I'm living a life of a victim, I need to do this, I need to fix that, and that is creating a lot of different kind of mental health problems. So we also have a center for ethics, spirituality, and mindfulness here. So that also we are doing a lot of research in that area. So these are a lot of the old ways and the innovative ways, and in the panel on 9th I'll be speaking more about it. So with this I just close my welcome address, and I welcome all of you once again to this wonderful conference. Thank you.
Thank you for enlightening words, sir. I now request Dr. S.D. Gupta to kindly address the audience. Dr. S.D. Gupta is a public health expert with a distinguished academic and research career. He obtained his MD in Preventive and Social Medicine from India, PhD Epidemiology from Johns Hopkins University, Baltimore, USA. Dr. S.D. Gupta is Secretary General of Southeast Asia Public Health Institutions Network, CPHIN, supported by WHO. Sir.
Good morning, distinguished guests and friends in this very important event in Jaipur. Many of you might have come to Jaipur for the first time, and maybe to India for the first time. Let me do this honors duty to welcome you to the country and to the city. City has become beautiful with your arrival. That's what I can say. The weather is somewhat getting notorious this morning, all of a sudden. But anyway, you all are very familiar with this kind of weather, so you should enjoy this. I'm very thankful to Dr. Vimal Sharma, who is a tech professor with HMR University, who kept on encouraging us and doing things. Dr. Catherine Robinson, Angela Simpson, Dr. Schultz, and Dr. Pan. It's a great honor to have you with us and to make this event very important. Mental health, as we see, is now recognized that it is a significant morbidity, not only in India, but all over the world, and not only in the urban areas or among the affluents, is equally there in LMICs as well as rural areas and among poor. You all know it very well that there is a health transition going on in this part of the world. What you have seen in Europe and the Western world long back, and probably that transition is over in that part of the world, the non-communicable diseases, especially diabetes, cancer, cardiovascular disease, hypertension, and mental disorders, have changed the scenario over there, where majority of the disease burden is on account of these non-communicable diseases. But the developing world, especially India, what we see, that disease transition taking place, health transition taking place, economic transition taking place, social transition taking place, demographic transition taking place. The lifestyles are changing, the job and the stress is increasing, and what we see, increasing disease burden due to these diseases which I have just mentioned. So close to 65% of the total disease burden now in this country is on account of these non-communicable diseases. And you might be aware that India is capital of diabetes. So we have started feeling pinch of these non-communicable diseases. When we talk about non-communicable diseases, we generally talk about diabetes and all that, but we rarely talk about mental diseases or mental health problems. But what we see and the projections for future in next 5 years, 5 to 7 years, the disease burden in terms of disability adjusted life years will rank number 2. Mental health disorders will rank number 2 for disability adjusted life years in this country. So we see the situation with great concern. Incidentally, the government of India thought about it and decided to launch National Mental Health Program and came up with the policy and strategy. How far it has gone onto the ground? Because we really do not know how to implement mental health services. It's all in the manuals and guidelines. So we have to come out with the approaches. So it's a kind of difficult thing considered that, and India already and most of the developing countries are short of psychiatrists. They cannot reach over there in the far-flung areas. Even at the district hospitals, we still don't find psychiatrists. And the problem is increasing. The treatment is not available, and you all know the reticence shrouded around mental health illnesses. People do not come out and they do not disclose, or they don't seek treatment. And the other thing is there is no treatment available for majority of population for this, even if they are diagnosed. So that is a situation that we face in the developing countries. India also faces this. The motivation to start working on mental health comes from Dr. Vimal Sharma, and we should thank the Indian Council of Medical Research. I think Dr. Babu. Okay, so he will be joining us on the 9th. So we decided, being part of the Indian Council of Medical Research, we could manage to get a study based on interventions. So the idea was, can the frontline workers be trained in identifying mental health disorders? Can those patients who are identified by them during their visits to households or while people come to the primary health centers or lower level health facilities, the treatment could be provided to them by a team of psychiatrists from Government of Rajasthan Medical College here, Vimal Sharma and his colleagues and my colleagues. So that worked very well. There are very interesting findings we had with that. Firstly, people did not know about knowledge about mental health illnesses. The health workers also did not know how to diagnose, and even they did not know what are the mental health disorders. So there was a big knowledge gap on the part of the people in the villages and knowledge gap among the frontline workers, and of course the skill gaps in diagnosing. So we used this tool, GMHAT, for diagnosis. I, being an epidemiologist, very particular about the validity and reliability of any tool, so we tested that, and we found rarely you find sensitivity and specificity both high in any situation. And here we found this was above 90%. Having realized that, we used this, trained the frontline workers, went out to identify cases who are suffering from any kind of mental disorders, brought to the camps, which was organized every 2 months, and we found that the things can be done. We are currently searching how this mental health program, national mental health program, can be implemented. That's one big complex rubric we were trying to crack. And we were very satisfied. We do not have the solid results to share with you. We tried to make it a quasi-experimental type of study. But we succeeded in managing and controlling the study. All said and done, we could really see that this works. So, in this illustrious group of mental health specialists, practitioners, and researchers, I think we should be able to see this through in these 3 days. I believe Dr. Vimal Sharma is going to give training in use of GMHAT the first 2 days, and the third day we will have intensive discussions on the challenges in mental health, in diagnosis, identification, providing treatment, and how to do so. That's what we all are going to talk about. So let me welcome you all. We in India are looking for this. Can we suggest to the government? I have plans to start and convince the Director General of Indian Council of Medical Research to start a task force study in India on 5-6 sites, using the same tool, using the similar approach, standardizing it, and see whether this works. I think we can be more scientific, more technical this time in planning that study. My motivation for this doing mental health work comes from, I did not know at that time that we are doing some important thing. Way back in 1978, around 1980, did a community psychiatry project where we tried to increase awareness and provide treatment with the help of the psychiatry department of the Medical College Jaipur. That went on for 3 years. But at that time I did not know this is so important. But my confidence comes from there, that we can do. So let's look for, and this community where we were doing this community psychiatry study was a migrant community from, you all know in 1947 India was divided. So many people, I think this was the world's largest migration of people across the borders. So a lot of people came from the other side of the new border, and they settled mostly in North India, and a good number of them settled in Jaipur. So they were already under stress of migration, and the first generation that migrated had severe problems with them. That was one of the reasons we started that. So I think my belief is we can do. And let's find ways how can we do and test those models and suggest the government if they can adopt that or try that and operationalize effectively their national mental health program. So with this, of course, it is a bit longish, but I just wanted to share why we are here and what is the motivation behind this, and then finally come out with our recommendations, what we feel, what we can do in this area. Thank you very much for patient hearing, and let me welcome you all once again to this important workshop in IHMR University. Thank you so much.
Thank you, sir, for your enlightening words. Now I request Dr. Vimal Sharma to kindly state the purpose of this 3-day training program. Dr. Vimal Sharma is a professor of International Health Development, University of Chester, and consultant psychiatrist, early intervention in psychosis services.
Very welcome. I will very briefly, and I thank Nutan and team to outline the program, so I don't really have to say anything about the outline of the program. I'm delighted that a public health specialist talked about mental health, and therefore I don't need to talk even about mental health. I think I'll just give a brief outline of how this happened. Dr. Gupta called me one day, or I called Dr. Gupta one day and said, well, can we have some kind of get together so that we can talk about how to improve mental health of communities? Dr. Gupta said that our president, Pankaj Gupta, is quite keen to hold an international meeting. So then I approached Angela, our team, and Catherine, who has been working in Southeast Asia for self-harm initiative and predominantly trying to reduce suicide if possible and find out ways to do that. And I thought I may take your permission to deviate slightly and possibly ask these people to say a few words from each organization. Our intention was to have this meeting, which is multi-professional. Mental health is everybody's business. Multi-institutional, multi-organizational, multinational, and I'm delighted that we have representation from all states of India. Prakash Pade is sitting next to me. He has done enormous work in the GM head in Maharashtra, and we have the whole team from Maharashtra. We have from Madhya Pradesh, we have from Uttar Pradesh. Rajasthan obviously is, I'm sure, under Dr. Gupta's leadership, leading the project here through ICMR. I think if you can move on to next one, what we wish to do in next 3 days. I think the whole idea is how we can improve lives of people around the world, our communities. And I think it's a health and well-being, and mental health must be an integral part of health and well-being in that. And in that, we have to share our skills and knowledge to people so that they can apply in day-to-day life through training. We have to increase knowledge and understanding. What are the issues? How we can address them? And that becomes a part of research. I'm a simple-minded person, not a high-flyer statistician. So, and the research is to find the truth. And the truth only. How we can understand and apply the true findings in the communities. And more importantly, how we can work together in achieving that target. So in next 3 days, it's not the lectures which are important, it's the interaction between people to understand, to assist and to cooperate in order to make future plans. So this is the beginning, this is not the end. I also welcome our distinguished person, and I would say one of the most influential person in health sector, Professor Ved Prakash, who will be our chief guest. But I thought before you move on, if we can request from Thomas. Thomas is here from World Psychiatric Association. He is chairs the scientific committee, a very important person. So we could possibly start from that end, and a few minutes if they can outline what the purpose of organization. Thank you.
Thank you.
Well, thank you very much, Vimal. First of all, it's a great pleasure, honor being here today in Jaipur. My first visit to Jaipur, not my first visit to India, but Jaipur. So my name is Thomas Schulze. I'm from the University of Munich in Germany. But here I'm basically in my capacity as WPA Secretary for Scientific Sections. And in that capacity, that's really what makes me really happy to be here. Because, first of all, the WPA represents, as you know, more than 140 national societies. Also 72 scientific sections. And the section on rural mental health is one of these 72, and I may say so, one of those active ones. There are many sections, not all of them are very active, but some are very active. And the rural mental health section being one of them. So I would like to thank the rural mental health section today, Satish Malik, Anshuman Pant, and Vimal Sharma, who run the section, again, very much for organizing such a meeting. And I would like to point out that, just looking at the title, Improving Mental Health and Well-Being of Communities, International Training on Skill Development for Diagnosis and Management of Mental Illnesses Using Digital Technology. Wow, there's a lot in there. Now you can say, well, many titles have a lot in there, right? So everything you want is in this title. But then you look at the program, and when you look at the program, you really see what WPA likes. It's not just lectures, as you said. It's interaction, it's communication, it's learning about communication skills. So the next day, tomorrow, will be about this. So it's not just a few lectures and maybe when people run out of time. So you allocated a lot of time for very important learning elements. So I would like to commend you on that for that. This is really what we want. When I say we, that's WPA. And many people know WPA from, I hope they know from all those World Congresses of Psychiatry. Now we have a conference, World Congress every year. The next one will be in Lisbon in August. But also regional meetings, thematic meetings. these are our big signature meetings. These are our, I would say, glitzy events. But actually that's not WPA. Well, that is WPA, and we need these. But WPA lives through events like this. You know, WPA is not an organization that just parachutes in and then tells everyone what to do. No, WPA lives through the work it lives through the work on the ground. And so we need people that are dedicated to doing that work. And that's exactly what we are witnessing here. So I, again, would like to thank you, IIHMR, and all the other organizers for having this conference. This is needed, this is great, and you're leading the way. Thank you very much.
Hi, so I'm Catherine Robinson, Professor of Social Care Research from the University of Manchester, and I'm delighted to be back in Jaipur, seeing familiar faces, and hope to have some time to talk about research plans. And I'm really also honoured to represent the South Asia Self-Harm Initiative. It's a research capacity strengthening and research programme which is funded by the Global Challenges Research Fund, which is part of the United Kingdom Research and Innovation organisation. It's a partnership, so it's a partnership between some UK universities and organisations and universities both in India and in Pakistan. And our focus is on self-harm, knowledge about self-harm, attitudes to self-harm and experiences. So both from the perspective of people who have experienced an episode of self-harm, but also about communities and families and healthcare and social care providers. We're very much about working together to share knowledge, to not presume that work that's been done elsewhere will be relevant, but to actually work together in the UK and here, very much on a partnership basis, sharing knowledge, exchanging experience. And it's about also building capacity for future research. So it's not just about the research threads that we've been funded to do, and those two threads are about self-harm, so some surveillance work, very much building on the work of the WHO about how you set up and administer registers in secondary care, but we're also interested in looking at surveillance in primary care and community settings. So we're at the beginning of our journey. We've had the privilege of a set-up year, and we've been working together over the course of the year, and we're getting closer to the point where we'll start to collect data, we'll start to work together on outputs and outcomes from that. And the aim is to inform local organisations, to inform local healthcare providers and communities to reduce the incidence of self-harm and to reduce the incidence of suicide. But we're also very aware that it is a major issue, it is a considerable problem, and that people do self-harm, people do take their own life. So we're also interested in what the outcomes and consequences are, and how we might help families, and how we might help communities after those sorts of events. So I'm really pleased to be here, and I think it's great that we've had the opportunity, and well, thank you for inviting Sashi to be part of this and to support the programme. Thank you.
Good morning. It's my turn now to you hugely for welcoming me to Jaipur and for inviting me to contribute to this wonderful event. I am Executive Dean of Health and Social Care at the University of Chester. Our Vice-Chancellor wasn't able to attend this meeting and has sent me as his envoy. I can talk to you very briefly about a separation essentially of my professional background, which is in mental health, nursing and in self-harm and depression in primary care, and also in relation to my wider executive role at the University of Chester. I'll start at the University of Chester and tell you a little bit about our institution. We've got a 20-year history of health professional education and research, which we're very proud of. We work with communities across Cheshire and the world to ensure that we provide education that's meaningful and relevant to those local population groups. As with all areas of the UK and what I'm hearing globally, mental health is a huge emerging issue, and there are challenges within the university population as well as within general health around this issue. With that in mind, pretty soon after my appointment in Chester, which was about a year ago, Professor Sharma came to see me, and we discussed our mutual interests in this area, and particularly the work of GM HAT. We're hoping very much to work together much more closely with Maine as we begin to look at the challenges of student mental health problems arising in vast numbers in the United Kingdom currently. So pulling back to my experience as a researcher, my research was in self-harming and in relation to primary care mental health. I'll be talking to you a little bit tomorrow about some qualitative research in self-harming that I undertook several years ago. My interests feature on the area of self-help, on preventative care, and now as we begin to move into digital solutions in mental health care, we'll be looking with Professor Sharma to see if it is possible to use the GM HAT to help to predict student mental health issues within our own population groups. I think this is a very interesting area of work to be involved in currently. So I'd just like to leave my contribution to the morning there now, but to thank you enormously and to say how powerfully I'm hit by Jaipur's culture. It hits every sense all at the same time, and you know, it's wonderfully exciting to be here. So thank you very much indeed.
Thank you very much. I would like to thank the IMH and Vimal for inviting me here. And of course, from the WPA Rural Mental Health Section perspective, this is our first big event outside the parent body that Thomas is scientific chair of. And I'm absolutely delighted. I mean, Jaipur is my alma mater. I actually did my MD from here in psychiatry. This is going back 97, and I was pleasantly surprised. I was the Jaipur Association of Resident Doctors president, and I was pleasantly surprised by co-president in the university, Pratap Singh Kachariwas. He's the transport minister now. I think he was just elected last month, I think. So a lot of fond memories, and I did my MD under Dr. Advani and Dr. Shiv Gautam, but then I moved to UK and trained another 8 years in addictions, general psychiatry and psychiatry of the old age. And we have been doing this sort of initiative at the WPA Congress that Thomas was talking about. One of the issues that we're discussing all the time is the challenges and solutions in sort of rural mental health. And of course, what happens there is that, you know, there needs to be connection at the ground level. I was, by the way, part of the National Mental Health Program
whilst I was doing the MD here, which of Gautam, and I think Jaipur is one of the centers to train the professionals. I think the key thing here is, I think there was a slide Vimal is going to show in terms of the number of psychiatrists in the West. So I think the number was 17 in the UK, in 100,000 population, 17 psychiatrists. In Australia, where I am now, I moved to Australia as the director of the Rural Mental Health Service in 2013. I think we have 10 per 100,000 population. At the women's slide, I think it was 0.5, 0.05? 0.3, yeah, so it's 0.3 per 100,000 population. The other thing is that I was quite struck where I'm also a visiting professor for the SMS Department of Psychiatry. And I was here in July and I was teaching the residents, and one of the residents met me in the evening, and he mentioned that he couldn't contend because he was doing a clinic. And I just asked him, how many patients did you see? So they'd seen 200 each. Yeah, 200 each. And you know, so I'm really, I've got a sort of mainly clinical, obviously have my research and other hats, but I do hardcore clinical work back in Brisbane. And you know, if my juniors, they get 6 to 9 patients, so more than 9 patients a day, they'll start crying. And here we have not only, you know, in terms of the West, a very small number of psychiatrists, and even the small numbers we have, they end up seeing so many patients that really, I mean, I'm just wondering if I was seeing now, in a couple of minutes a patient, I won't be able to do the justice in terms of diagnosis and, you know, formulating a management plan. So an initiative aimed at really empowering the frontline health workers, not just mental health workers, because you might not have mental health workers. The frontline health workers is the key. And I think that GMHAT is fantastic. And I just heard from Dr. Gupta about the sensitivity and the specificity being more than 90%. So it's a no-brainer where things need to go, really. And the Students' Mental Health Initiative would be a wonderful development. So I thank you all, and I hope that there's going to be a really good interactive session, because that's what we really want. We don't really want to lecture. It's about you know, thinking together. I've been privileged to have fellowship from India, the UK, Australia, and New Zealand. So, you know, to share, you know, the experience, different cultures, and how to be able to actually make a difference at the ground level. And that's the most important thing. Thank you so much. Yes, thank you.
Thank you so much, sir. Thank you so much, ma'am. Moving forward, our guest speaker for this session is Dr. Ved Prakash Mishra. Dr. Ved Prakash Mishra is currently the chairman of Academic Committee, Medical Council of India, is also the Chancellor of Krishna Institute of Medical Sciences University, Karad. I request Dr. Ved Prakash Mishra to kindly address the audience.
My esteemed friend, respected Dr. Vimal Sharma, dignitaries on and of the dais, resource persons, delegates and participants to this very historical moment, which I think I am blessed to be participating in. The entire purport, ladies and gentlemen, which I am wanting to put across is what is the mandate for such a venture, what ought to be the scope, what is the relevance, and what is expected to be a way forward. When I am wanting to enunciate that, I am taking certain parables for the purposes of establishing what I am wanting to put across. We are all well aware that when we are contemplating, and WHO has contemplated a definition of the word health, and to put it succinctly, positive health. I am just taking the parable, 4 important parables in it. It's not just absence of disease or infirmity, part 1. It's a sense of total well-being, part 2. And that well-being incorporates physical well-being, mental well-being, intellectual well-being, societal well-being, spiritual well-being. It is this entirety of the dimensions which is expected to be taken into consideration when we are talking about extension of positive health. Having taken this absolute definition of health, the second important consideration is International Charter has contemplated this to be an international human right. It's not only international human right when I speak in the Indian context. I'm just wanting to make the position loud and clear, therefore I'm saying what exactly is the mandate in which we are required to be working. In our Constitution, Chapter 3, we contemplate fundamental rights which are justiciable in this country. These fundamental rights, I am specially referring to Article 21 therein, which mandates that every citizen is guaranteed with life, liberty, and it has been interpreted that this guarantee entails dignified life, decent life with total liberty. I am putting this ambit very clear. It's no more a human right that we are contemplating when it comes to extension of health. It's the constitutional mandate, the fundamental right vested with every citizen, and in the context of what exactly has been enshrined in the Constitution for ushering in. It says, ushering in of a welfare state. The ambit of welfare state operationally has been structured by expert committee constituted in the year 1952. It identified fulfillment of 18 parameters which ultimately will be in ushering in a welfare state, and of those 18 parameters, the first two listed at serial number 1 and 2 I am citing. Serial number 1 was health and serial number 2 was education. I am not dealing with the 17 parameters, I am limiting myself to ushering in of welfare state, contemplating the most important parameter of health being extended to all, and that is the constitutional mandate. It is in this context I am wanting to put across placement of mental health when it comes to extension of health to every citizen of this country. No doubt, when we contemplate a policy plan, number one, policy in regard to mental health has been put into place by Government of India. Operational plans have been worked out, but then they have to be viewed in the context of four important things. What is the level of amenability? What is the extent of availability? What is the extent of affordability? These are the important considerations which have to be taken note of. Number one, is the population in the developing world aware about the scope, the mandate, the relevance and status of mental health per se? The answer is very no. This has to be viewed in the context of certain prioritizations as a result of which the scenario operates. Prioritization of mental health in the developed world, even if it is intended in terms of awareness, in terms of amenability, in terms of availability, in terms of affordability, is a distant dream. It is in this context, this reality, the world itself is fragmented into two distinct parts. It is plagued by inequity, it is plagued by paucity of resources, it is plagued by several prioritization considerations, and therefore to say that we are contemplating a global health program in which mental health extension is to be a human right extendable to all is more of a myth than reality. Until and unless the considerations which are operating as the great limitations, great constraints, they are taken note of, we will be only talking of dreaming things rather than actualization in the real sense. And therefore, I am identifying three important considerations which have been picked up by Government of India in regard to planning of extension of medical health program to the citizens of this country. Number one, generation of manpower. Ultimately, it is the manpower which will be taking the mantle of responsibility. Even if the resources are there, if the manpower is not there, it will never be in a position to materialize and reach the targeted goals, and therefore the generation of manpower. I am happy that as the chairman of the Academic Council of Medical Council of India, I had the onus, and when I am standing before you, we have definitely taken initiatives for the augmentation of trained professional health manpower in the domain of mental health in this country. Mind well, the ratio of 1:1 for every postgraduate teacher resulting in one registration in psychiatry, it was altered under the initiative of the Academic Council, and that was the first subject where the ratio was altered from 1:3, resulted in one go, existing number of avenues for postgraduate medical education in psychiatry getting converted 3 times in the year 2011-2012, and therefore that particular context has resulted in definite avenue for the augmentation of the trained health manpower. There was a second consideration, and that second consideration was manpower just does not get created only in terms of the postgraduate teacher available. There has to be avenues in the concerned medical schools for the purposes of starting of the Department of Psychiatry and then enabling it to be having postgraduate courses. The infrastructural requirements were revisited. The requirement of personnel was revisited and the ratio was altered, including the clinical material which was augmented in terms of the traditional setup of 30 beds constituting a unit was altered to 20 beds constituting a unit. The required percentage taking into consideration the daycare nature of the services which are required to be rendered in the domain of mental health and psychiatry, that proportionate reduction of the required occupancy also came to be altered, as a result of which in last 4 years the extent of avenues generated for postgraduate medical education in the domain of psychiatry in this country has undergone threefold augmentation, which I think is a reasonable number, may not be a sufficient number. But then, the level of awareness which is the hallmark of the entire context, the prioritization which has to be put across is something very significant. As very rightly put in by Dr. Vimal Sharma, if the statistical connotation of population is to trained health manpower in this country is to be viewed in terms of the ratio, then 12th 5-year plan midterm appraisal says that for every 10,000 population we have got only 0.3 psychiatrists available in this country, as against the targeted proposition which is substantial and very heavy. The gap is huge, the gap is big, and therefore contemplating that only trained psychiatric personnel will be in a position to dispense the mantle of responsibility is a far cry. And therefore, as very rightly put in by Dr. Gupta, frontline health workers, they are the ones who are required to be equipped, they are the ones who are required to be trained, they are the ones who are required to be put across with definitive skills, they are the ones who have to be put across with that competency-based programs which will be in a position to undertake the responsibility and the mantle of responsibility, because this is the only way out in developing world. And I am here to record my sense of gratitude to Dr. Vimal Sharma and his entire team and Chester University that GM HAT program which has been put across by them is something which is very meaningful, very focused, very targeted, having absolute scope with total relevance and impact. I am in a position to put across this with certain degree of absolute authority, in as much as with Dr. Behere and Dr. Vaishali Tendulkar, who is here as a participant, a doctoral degree project was assigned to her, and I had the fortune of chairing that scientific committee. Therefore, I am knowing ins and outs of it, wherein in a total sample of 400, the Marathi translation, the vernacular translation of GM HAT was worked out, it was tested, it was piloted, it was standardized, and in terms of the very declaration which you talked about, the sensitivity and specificity, let me put it across, the sensitivity and specificity which was worked up for that particular Marathi translation in the case of tested module was absolutely on par with the propositions, maybe 90% and more, which have been worked out over here. We are a country with multilinguistic orientation. GM HAT program in the Indian context cannot work only if it is in Hindi. It will work in Hindi heartland, but it may not be in a position to take up in remaining states. And therefore, today I am happy to share with you a targeted work in Karnataka in terms of the language there is already on. A targeted proposition in Tamil Nadu has been undertaken and the work is on. Maharashtra, perhaps we have completed the entire thing and the Marathi version of the same is validated. But we have 16 official languages included in the schedule. And therefore GM HAT program, until and unless is worked out in 16 regional languages, under scientific study it is tested, piloted and validated, we will not be in a position to use even that handy tool which is so significant and so impactful. Therefore the targeted proposition is undertaking the onus of making translated versions in vernaculars in at least 16 operational languages in this country, so that a validated program in terms of availability of GM HAT as a module or as a dispensation target is available to the people in this country. Number 3, only validation of the program will not do. This validated program has to be translated into impartable skills and impartable levels which are required for the purposes of elicitation. This cannot be without a structured mechanism. This cannot be without institutionalization of the same. We take all these programs more as a charitable programs where we are wanting to be creating people. Creating people is not a joke. We have to standardize the creation of the people. We have to ensure that the targeted proposition is not only initiated, not only inculcated, it is internalized and it is diligently certified that here is the level of workers who have been created for the purposes of dispensation of these targeted propositions in this manner, which has been not only, for which they have not only been trained and oriented, they have been duly certified for that purpose. And therefore, ladies and gentlemen, mental health in any developed country cannot be dealt in the name of charity is my first conclusion which I am wanting to be putting across before this learned gathering. It has to be a program which is well articulated. It has to be in the program which is well put to resources. It has to be a program which is worked out with frontline workers and professional workers working in tandem. It will have to have institutionalized mechanisms for the purposes of generation of training and orientation. Then only the skilled workers will be in a position to be created for dispensation of the responsibility. The third important aspect which I am wanting to put across is resource generation and resource allocation. Until and unless mental health is put across as a priority in the domain of extension of health and the resource allocation for the said purpose is worked out, then only meaningful outcomes can be generated. If I am wanting to put across the present proposition, ladies and gentlemen, I am not wanting to criticize anybody. As health workers and as professionals, we need to put across things very rightly put in by Dr. Vimal Sharma that truth has to be spoken in the name of research because research is the truth and truth is the research. Resource allocation, if you take into consideration, any 5-year plan program right from 1952 till this, even the 13th 5-year program, it contemplates only 1.4% of GDP to be put across in health, and out of that 1.4% GDP, what is allocated to mental health is 0.27% of that 1.4% of GDP. Now, if this is the resource allocation that is required to be putting across, what prioritization we are in a position to pay. And therefore, resource crunch is one of the biggest factors which comes in the way when it comes to extension of mental health. Good. People in this country are not well aware, and therefore, in terms of they putting across in the form of their legitimate expectation for the purposes of actualization is not there. But that is not a good situation. That's not a healthy situation. The need is of generation of the awareness. The need is of making people understand. The need is of making resources available. The need is institutionalizing the mechanisms. Need is not only institutionalizing the mechanisms, supporting the mechanisms both in terms of the governmental agency and the private support which is expected to be operational in this country. The fourth dimension which I am putting across in the Indian context is, ladies and gentlemen, something very serious. In the backdrop of resource crunch, in the backdrop of availability of trained manpower, in the context of poor level of prioritization, in the context of impaired levels of awareness, and in the context of non-availability of healthcare facilities and non-availability of extension to the same, there is yet another important problem which has to be taken note of, and that is the entire development of health sector as a whole. Over a period of time, it is getting demarcated into two distinct cells. 1952, the public sector in the domain of health was to the extent of absolutely 94%. And when I am talking to you in 2018, the public sector in the Indian context in the domain of health, it has shrunk to 18.76%. It is the private sector which has been operational in a very big way in last 70 years. And therefore today, if I am wanting to put a real picture in terms of the facilities available and targeted population to be catered, there is an inverse pyramid which has taken place. Nearly 20% of the facilities are to be availed by 80% of the people, and 80% of the facilities are availed only by 20% of the people, and this is a reverse paradox. If this paradox operates, ladies and gentlemen, in that situation, what is going to be a scenario is something which is tough to digest and difficult to handle. I have only 4 statistical connotations to put across to justify the magnitude of the problem. You and me will never be in a position to structure the strategy through our initiatives if the magnitude of the problem is not deciphered with clarity. 4 important things I am putting, and again I am not making a comparison to be deducted in any adverse manner. United States of America is 25% of the Indian population. United States of America economy is 16 times more than the Indian economy. The Indian GDP in the year 2017 was 142nd among the country's list. GNP was 147th among the country's list. Amongst this, nature of the burden, population to be catered, the proportional GDP allocation was 3.8% as against American allocation of 16% or 16.7% precisely, in terms of 1/4 the population size of the country and economy being 16 times more, in which mental health prioritization was to the extent of 18.6% of the total allocation as against 0.27% allocation in this country. Why I am making this connotation, ladies and gentlemen? As if this is not enough, there are two statistical readings which have to be taken note of. The extent of impoverishedness, the dominance, poverty, the ignorance, the levels of socio-economic demarcation and the various demographic considerations are so acute that I am just putting across two statistical connotations. One bout of critical care in a given family, in 32% of the population in this country, one bout in a family results in an invariable deaths to the extent of 98%. Now this is something which is devastating. This is something which is mind-boggling. Imagine in such a scenario when in the case of generic health, I am not talking of mental health, generic health, the paucity is so acute to contemplate that when I am not entitled to place even in a hell, me being given heaven and booking for a seat in heaven is only a heavenly abode from me, more in imagination and less in fiction. The contrast is huge. The dimensions are very, very demarcated, and therefore what is the way forward is something I look up to. The way forward is governmental support is there because of policy in place. Prioritization has been indicated. 12th five-year plan has brought out that particular change. Resource generation is poor, resource crunch is acute, levels of awareness still have not been worked out, and therefore the need is how exactly this level of awareness is to be altered, how it has to be augmented, and that is possible only by creation of a stream of committed para-health workers, which in the present context, one of the biggest achievements in case of public health program in India has been ASHA workers, which have really created a ASHA in the minds of people of this country. Program has gone well. Now if ASHA worker can have a kit on maternity and child health welfare, if ASHA worker can have a kit on pediatric dimensions, if ASHA worker can have work on obstetric and gynecological dimensions, why ASHA worker cannot be availed for the purpose of GM hat orientation and broadening their kit for the purposes of mental health is something which I am wanting to look up to. A workforce which is already put into place, which is already working and which has generated and which has proved to be of consequence and relevance. The need is if the kit which is put across to these workers in terms of structured orientation and certification and the various bridge course that we are contemplating today, in spite of the fact that we are talking of the bridge courses in pharmacological domain, in spite of the bridge courses that we are talking in regard to maternity and child welfare, some bridge courses in regard to geriatric healthcare and good number of courses in regard to pediatric healthcare, even today we do not have a broadening of the para-health workers in the context of mental health care. The reason being, the tool is not available. The reason being, the standardization dispensations in the domain of research which are to be evoked, they are not there and they have turned out to be a big handicap. Ladies and gentlemen, I am wanting to put it across over here. Learned brains are sitting over here. Interactive deliberations are expected to take place. My submission which I look forward to is, should there be, and what is the possibility of GM hat as a tool to be incorporated in the kit of ASHA workers through appropriate structured training worked out under the aegis of not only medical schools but also the specialty associations undertaking that responsibility, wherein a structured program is created. I am giving one example. The big issue in the country in last 10 years was who is to certify obstetric sonography. A big problem was there. PSPNDT Act was coming in a big way. And I am happy a study group which was headed by VV suggested that obstetricians and gynecologists to be put across too. A structured training program on obstetric sonography in medical schools and recognized centers, and then with that particular course certified, they would be entitled to sign the obstetric sonographic reports. And ladies and gentlemen, this particular venture has come as a big success, and a huge issue which was created and contemplated stands augmented in a reasonable and a substantial manner. It is this experience, ladies and gentlemen, I am wanting to put across. I am not here to advise you. I am not here to guide you. I am only wanting to tell you, having been part of the planning process of this country for a reasonable time, the concerns and the limitations in which the things are required to operate, until and unless the scientific input in terms of structuring of a tool and modalities which are to be given to the paramedical workers and the frontline workers, they remain more of a quack and a jugglery rather than they being able to be really delivering a good output. Institutional deliveries in this country, ladies and gentlemen, which was one of the biggest problems. Today, that problem of domestic in-house delivery vis-a-vis institutional delivery, it stands sorted out in a poor country like ours, Dr. Sharma, to the extent of 72%. Now today I can say 72% of the deliveries by and large either are institutional or they are under the supervision of an ASHA or a DAI or a trained DAI as you call. This change has taken place over a period of time. There are certain success stories. There are certain modalities of initiatives which have turned out to be success in the domain of public health. We need to work out one for the purposes of mental health. Accusations are not going to result in any solutions and any salvations. Learned brains have to think together, taking into consideration the constraints, taking into consideration the limitations, taking into consideration the concerns, and also taking into consideration the challenges which confront. They are bound to be there. There has to be a way forward and there has to be a way out. I am sure that the suggestion which I am wanting to put across is, can there be an initiative, and let that be worked out in terms of deliberation so that it can be taken to the planning and higher levels for the purposes of policy decision making by the Ministry of Health and Family Welfare, including the Niti Aayog in this country, to take up that yes, GM Hat is a tool which should be declared as a valid tool to be adopted by Government of India for the purposes of training of frontline health workers in a structured format. 2. If that is accepted, let the government and various agencies take the onus of getting that translated into the various regional languages for the purpose of operation in the entire country. And 3. Work out a training module which I think is worked up for the purposes of paramedical health workers, including frontline health workers, in a specified duration through the form of a bridge course and working out certification there too. Involve various medical schools. Today we have got a network of more than 500 medical schools in this country which can be given the onus and structuring of this entire dispensation. And number 5, should therefore GM Hat as a tool for the purposes of inculcation and orientation of schools not be incorporated into the undergraduate curriculum of medical education in the form of at least 3 structured credit-based competencies, so that a learner right from the educational days when he is being trained and oriented, he is oriented into this particular module in terms of a definitive credit. Now that next year 2019-20, competency-based curriculum is already put into place. And I am happy to share with you that I had the fortune of shaping that entire competency-based curriculum, in which public health competencies have been totally equated with mental health competencies. The 2 areas of competencies which have been balanced together in the competency-based undergraduate medical curriculum is the weightage which was attributable to public health competencies defined is equivalent to the weightage which is attributed now to mental health competencies, and the balance has taken place. So as far as the teaching and training part of the undergraduate curriculum is concerned, it has been incorporated. But yes, GM Hat even today is not an addition or incorporation in that particular curriculum. Therefore, my submission is, if we are able to structure a module which could be incorporated in the undergraduate schedule. It can be definitely taken up and put across to consideration. It is in the process of launch. Within the competencies in mental health, GM HAT model for the purposes of inculcation of competencies could be inbuilt in the curriculum itself with attribution of designated as a level of competency and proportionate credit on that particular count. That becomes one important area which could be worked up in the training schedule, so that the graduates who are coming out of under this program, they will be well oriented and they will be in a position to take that responsibility on their own out of the structured training and formatting. There are various thoughts which can be worked out, ladies and gentlemen. I am not going to really tax you with what I intend and what I want things to be done. It is not I. It is we who should be in a position to evolve, who should be in a position to think, who should be in a position to rationalize. If I am to conclude, I have only 4 things to put across. A, the problem is acute. B, resources are poor. C, manpower is non-existent. And D, legitimacy of expectations have to be fulfilled. Against these 3 contrasts, if the human mandate is to be fulfilled, then we have to be equipped. Here is an equipment in the form of a tool which can turn out to be a good handy mechanism. It has to be structured, to be incorporated appropriately in the form of training of skills in all 3 domains, the cognitive domain, the conative domain, and the psychomotor domain, and then should be standardized for the purposes of putting across in structured training program both for health workers and frontline health workers, whereby we prepare a set of people to be put across for targeting the venture. There could be many other things which could be taken up for discussion, but ladies and gentlemen, I thought, I'm grateful to Dr. Vimal Sharma and all of you that whatever little I had in my mind in entire shaping and formulating of the scenario, I said, I need to unload this somewhere. And therefore I said, I am not here to advise, I am not here to guide, I am not here to counsel, I am not here, I am just wanting to unload myself. I was feeling heavy, I was feeling suffocated, and in that entire venture I thought I need a set of people where I should be in a position to unload myself, and I thought there cannot be a better place than Jaipur, and there cannot be a better university than IMR, and there cannot be a better people like you there where I should be in a position to unload myself. I am unloading, but in that unloading, I am not loading you, because we have to offload the problems of the people at large. Thank you very much.
Thank you for your words of wisdom, sir. I now invite Dr. Ashok Kaushik, Dean Academics, IIHMR University, to kindly propose the vote of thanks. Dr. Kaushik has served in the Indian Army for 34 years and was also an administrator of UN Hospital in Sierra Leone, West Africa. Sir.
Good morning, dignitaries on the dais, participants. It's my pleasure to extend a vote of thanks. Dr. S.D. Gupta, he has created a learning environment at IHMR, which we all like. He keeps nurturing us and he keeps this environment alive. I'm thankful to Dr. S.D. Gupta for his presence here. Dr. Pankaj Gupta recently joined us. He extended full support in organizing this training program. I'm thankful to you, sir. Dr. Catherine Robinson, Dr. Angela Simpson, Dr. Anshuman Pant, Dr. Thomas Schultz, they all took out their precious time and made an effort to be here with us. And I hope in the next 3 days we'll definitely learn by their experiences. I'm thankful to you, sir. You, madam and sir. Dr. Ved Prakash Mishra, with his talk, he seemed very committed, and the way he talked about the efforts, the situation of mental health problem in India and efforts being made, and how
GM Head can contribute towards alleviating the problem of and the peripheral areas. I'm thankful to you, sir. Dr. Vimal Sharma is with us for last many days, and he was making effort, talking to people, arranging for things, and he really helped IHMR to organize this program. And lastly, I am thankful to organizing committee, faculty members as well as student members, that they have made efforts to make it a success. Thank you so much.
Thank you, sir. I request all the esteemed dignitaries to kindly proceed for the group photograph downstairs outside the MDB hall. This will be followed by high tea, and we will resume the training program after 20 minutes. Thank you.